Well, good morning, everyone. I'm David Kolko. I'm from the University of Pittsburgh School of Medicine. I'm just waiting. Great, thanks. And it's a real privilege to be here and contribute to this discussion. I was asked to talk about enhancing behavioral health services in child welfare. And this is a topic that probably takes a fair amount of time to sometimes digest. And I think this is one of the reasons, what you see on the slide. We all know about the ACEs, we all know about adverse childhood experiences, but they're listed here on the bottom. And one of the take-home points, I think, for me about this particular figure is that this occurs early in life, but the second point is it sets in motion a cascade of impairments that don't end, unfortunately, until death. And for some of these kids in the child welfare system, they have much higher rates of almost all of these, including early death. So I think this is a way to ground us in why is child welfare an important system to include in this conversation. So let's talk about the child welfare system, and here's one slide on it. And these are the goals of child welfare. And what's interesting is there are three. And I think it's in this order. Safety is first and foremost, so protection from harm. The second is stability, that there's a caregiver who's accessible, who's involved, who's there, and a place to live. And of course, if you don't have a place to live, then the child welfare system mission is to find you a place. And then third, and again, I think in this order is well-being, which is really what we're focusing on primarily, even though they're all interrelated. And that is, how can we address the effects of trauma and mental health problems, as well as all these other family adversities. And so we're going to talk a little bit about the impact of working with providers serving child welfare that address the mental health issues primarily, so this third goal. So here's one slide, 30 years of work reduced into one slide, and kind of makes you humble when you look at what you've done in 30 words or less, but okay. My Scrabble history is paying off. So you can see we have two sets of studies, and again, I think this is a little bit of our work and other people's work as well. So you have training studies. What do we learn about training effects? What do we learn about the impact of providing that training on the use of treatment in the real world? And what you see in the training studies is that 2/3 of the staff will complete a training. We've learned that it's important to train supervisors. We've already mentioned that turnover is a problem. I'm saying it's a constant problem. And what we've learned is that some techniques that clinicians are taught they don't want to use. Sometimes those techniques are actually the most important ones, like the core ingredients. So that's an interesting challenge. On the treatment side, we learned that 2/3 of those trained will deliver an evidence-based treatment. The quality is, for the most part, reasonable, adequate. We've learned that delivering an EBP in a community setting is much more effective clinically than using routine care. But at the same time, we recognize that sustainability is a major challenge, and this is an area in which I think we need a lot more work, both clinical work as well as research work. So I wanted to say something about the three main areas in which child welfare services are being delivered in terms of mental health impact by primarily contracted mental health providers in a community. So the activities, the good news is that we have tools. You know, we have several tools. Many of you probably know these, study these, maybe even develop them. And one of the other benefits is that we are now using assessment. I use the word driven. It should probably say informed, but at least assessments are helping to inform treatment. There are many challenges, of course, one of which is the scope. They're not used that often. We have limited psychometrics. The utility of some of these measures is sometimes unclear. And it's a challenge to community agencies to pay for an instrument. So the cost is an issue. So in terms of next steps, what we might suggest is, one, let's think more carefully about coming up with a core set of efficient, valid tools that the community will use to do assessments of mental health problems. And the second is really for the child welfare workers, and that is we have to teach them to identify and refer for mental health problems. It probably is quite reasonable we could teach them to use screens to identify mental health problems, and then knowing that those problems are targeted by certain evidence-based treatments, they should be able to refer to those treatments. And I would point you to the work of Sue Kearns and Shannon Dorsey at the University of Washington, who are really doing terrific work in this area. So that was the first core function, which is screening assessment. The second is evidence-based practices. And again, good news, we have a fair number of evidence-based practices, all of which have a T or some other letter in them and for treatment, and it's really tough, and I know this gets kind of challenging sometimes to understand, and you can always look at settings like the National Child Traumatic Stress Network, and they have a list of a lot of these. That is really good news. Also, they're being used on a national, and I have to say international basis, and in some cases we've adapted those treatments to the needs of unique populations. Now the challenges are many, and that is that not many community providers refer to evidence-based treatments. They have mixed fidelity in some settings. We've already said turnover is a big problem. You invest in a clinician, that clinician leaves very quickly. That's a challenge. And then they're burdensome. You know, doing better care, if that's the right word, is harder than just doing anything. And I think that may be the biggest challenge that we face. How do you really help folks reach a higher ground when that requires more effort from start to finish? Next steps, one is perhaps train more people than 2 or 3 in a setting to have momentum. The second is maintain ongoing training and consultation. My colleague Monica Fitzgerald, University of Colorado, has done a lot of work trying to figure out how do you sustain evidence-based practices. And then finally, for the mental health providers, I think it's important for them to have kind of the child welfare system 101. You know, what are the regulations in child welfare? What are families expected to do? And what is it like to be in placement? And then the third area, newer, is trauma-informed care. And, you know, the good news is that some clinicians are actually involved in systems that are truly trauma-informed and cooperating. Sometimes they're called care managers. And so we're spending some time on team-based care in this area where we have PCPs working with nurses and then in some cases clinicians. But this is new. We don't really know what we sometimes mean by trauma-informed care. It's often difficult to coordinate across systems. We don't have much outcome evidence on whether or not a trauma-informed care model helps, and there isn't much reimbursement. So there are several next steps I mentioned quickly in the interest of time. One is, and we've mentioned this, interprofessional training. How do you take brokers, referral sources, caseworkers, train them with senior leaders or administrators and agencies who are also being trained with clinicians who are going to deliver the care? Ben Saunders has a community-based learning collaborative model that works on a very large scale to inform the entire community. The second thing we can do is enhance the capacity of the healthcare setting to actually directly address trauma. Howard Dubowitz, who was here yesterday, couldn't be here today, and Larry Wisso, I think, are involved in this area, which is bringing healthcare together with trauma care. And I think these are lessons we should learn. And finally, linking the doctor, the physician of record, the medical home with providers. This does not happen very much in the real world. Most of the time, we don't know that the other is involved. And so it's very difficult to coordinate. We have to figure out how can you coordinate, how can you communicate, and also how can we monitor progress across these systems. So I just wanted to mention what I'll call recommended next steps, because I know the word recommendation shouldn't be here perhaps, but I think of this as, okay, what else do we need to learn? And I know Elizabeth mentioned that she's doing a number of things with learning collaboratives. I have a colleague, Amy Herschel, who has an interesting study where she's comparing all 3 of these models. And so one of the things I think we'll learn very soon is what is the difference in outcome if you're going to train community clinicians in an evidence-based practice, whether you teach them using a learning collaborative, a train-the-trainer model, or just give them access to online material. I know there's a lot of work being done online. It'll be very interesting to see if folks really do profit from online training in a complicated evidence-based practice. Second is incentivize quality. And I see this happening in general health care. It'd be nice if this actually happened in child welfare, where we're trying to use value-based models or pay for performance. Julie Donahue is one person we're working with at the University of Pittsburgh, and I think she's done a lot of work trying to understand the impact of this kind of model. And then lastly, measuring reach and outcome. So it would be nice if we had a better take on to what extent are we actually serving the bulk of the population. We usually know a little bit about who we serve, but not to what extent are we reaching the population. Sometimes we reach 2%. And while that might be great relative to nothing, it's not terrific. And I would point you to the work of Lucy Berliner and Jason Lang, who have done a lot of work on collecting information and metrics to look at both reach and outcome. So by way of summary, here are some of the key, I guess, take-home points, and I just want to emphasize The third one, which is system socialization and collaboration, I don't actually have a good name for it. But I think something along the lines of how do you integrate care across systems? We're still trying to figure out how to do it within a system. But then what we have to figure out is how do you integrate the care from child welfare, from education, from mental health, and from health, the medical home. I think this is really the area in which we have to work. And I'm out of time, and I'm going to try to stay on time, so I thank you very much for your attention.